John.
So first of all, I don't generally put my picture on my title slide for talks, but I was in this building on Monday and saw this picture here. And I thought, who is that guy? And so that was 20 years ago or so, if you're looking for that guy. And that was, so in the neuroscience program, they decided to get a professional photographer for headshots for the neuroscience program. And I remember the photographer saying, do not smile. Whatever you do, do not smile. And that was the last professional headshot that I had. And then this one is more recent, and that was taken in December in India at a meeting that I had organized and was with a couple of my postdocs who were here. And I'm smiling in that picture because we were working on what I'm going to talk about today, which is what I'm excited to talk to you about today. I was asked briefly, and I will mention very briefly about my path, which is a weird one. So I grew up near Detroit, was about pretty close to a high school dropout. I won't tell you why. And took 3 or 4 years before I decided to go to college. And I didn't know what I was going to do with that. And I was big into running and marathoning and exercise physiology, needed a job and landed in some guy's lab in pharmacology at Michigan State who did hypertension research. And I was hooked. And that's where I went from there. So by the time I was close to graduate, he said, you should go to graduate school and get a PhD. So I did. And then I was finishing that, and somebody said, you should go to Johns Hopkins, this guy's lab, and do a postdoc, and I did that, and now I'm here. So that's the very short version. I can go into more detail if you want later. So what I want to do today really is talk about research that is going on in my lab, but also some other labs here at the U that has to do with modulating the autonomic nervous system that I think is coming on pretty strong in terms of a new way to treat cardiovascular diseases. So I'm going to start off with the acknowledgement slides because there's a lot of people to acknowledge. In my own lab, I've listed the people that are involved with the studies that I'm going to show you today. Dusty is my lab manager and also provides some great medical illustration for me. Jason Voss is a PhD student now at Vanderbilt, doing his postdoc, who really got a lot of this work underway. And then Aneeth and Chris are 2 postdocs. They're here in the audience. And then Madeline was an undergrad who's graduated, working in the lab and applying to MSTP programs right now. So. Now, there's several labs that I'm also working with, and I'll be talking about some of their work as well, with Lena Tokchova's lab, with Beth and Thomas working on vagal nerve stimulation, so working with biomedical engineering. Amanda Keller-Ross, who's sitting here, who's a new hire in physical therapy, is doing human studies, and we're starting to collaborate with her. Yogi Samichu, who many of you may know is the director of the MSTP program, but we've started working with him in terms of some inflammation work that I'm going to talk about. Alessandro is a faculty member in our department, a metabolism expert, and Angela Mortari, who many of you probably know, and Bill England. So just to mention, I'm going to bring all of them into line here. So I'm going to do a very brief overview of the autonomic nervous system in health and disease. I know probably many of you already know about this. And then I want to bring up why we would think about autonomic modulation. What would be the reason for doing that in terms of the things we're going to talk about. And then I'm really going to talk about 3 areas specifically of autonomic modulation. The first one are going to be preclinical studies we're doing now on renal nerve ablation. Many of you probably know this is being done in humans as a treatment for hypertension. Towards the end, I'll then talk about vagal nerve stimulation, which is also used. It's been in clinical trials for heart failure. We're working on it for hypertension. And then finally working with Amanda on spinal stimulation for treating exercise-induced hypertensive episodes in hypertension. And then I'm going to finish with a partnership we're putting together here at the university to try to actually go from bench to bedside with some of these therapies. So as a physiologist, I have to say something about homeostasis, and really that's the key in terms of a lot of physiology that we think about, and that's maintaining the internal environment of the body constant. And many, many systems are important in maintaining homeostasis. Now, this is the medical school diagram of the autonomic nervous system that we're going to talk about today. In red over here is the parasympathetic, and blue is the sympathetic system. And, you know, the things we learned for parasympathetic, rest and digest. I heard one was feed and breed or something like that, these silly things that were supposed to make us remember what it does. But the parasympathetic nervous system, as you know, it regulates heart rate, decreases heart rate, is important in salivation, lacrimation, urination, digestion. Sympathetic system is the fight or flight stress response system and does lots of things to basically mobilize energy sources, cardiovascular function for exercise. The new things that are coming out now, though, is the parasympathetic nervous system is thought to be anti-inflammatory. We're going to get into that a little bit later in terms of neural control of inflammation. And then the yin-yang relationship, the sympathetic system is thought to be inflammatory directly, and that's going to become important in terms of some of the things I'm talking about. Now, the simplistic view about the autonomic nervous system, and this is basically the lecture that I give to medical students, is that we have a controlled variable, has to be sensed by something, and that feeds back into the brain through negative feedback pathways, and then the nervous system controls effectors that affect that controlled variable. And then as I talk to medical students, I say, you know, we have a clinical normal range of this variable. And the idea with that would be that this variable is maintained within this range through this feedback control system. And then everything's fine. And so the sensors are oftentimes sending that information through afferent nerves to the brain. It can be hormonal signals as well, but usually afferent nerves. And then the effectors would be through the efferent nerves, innervating the heart and vasculature and other organs. So, and there's many variables that are controlled this way. Blood pressure is the one we think about most, and I'll be talking a lot about hypertension today, body fluid balance and composition, and I'm also going to talk about glucose in relationship to hypertension and some problems that those patients have with glucose regulation. So what's been well established now is that this condition of an altered sympatho-vagal balance, that in many conditions, the parasympathetic nervous system is shut down and the sympathetic nervous system is ramped up in disease states. So this is clearly true for hypertension. I wanted to mention being introduced by Gary, work that Gary did, Jay Cohn, Steve Goldsmith, quite a while ago, and patients showed there's increased sympathetic activity in hypertension, certainly in heart failure. But there's many other conditions where this is also true. Almost all the clinical chronic cases that were conditions we talk about, heart failure, renal failure, diabetes, are all associated with chronic activation of the sympathetic nervous system, and that's a bad thing. That leads to endothelial dysfunction, vascular remodeling, cardiac remodeling, things like that. So that's the problem. Now, why do we need to think about autonomic modulation, or the approach that I'm going to talk about? Now, the old way of thinking about the sympathetic nervous system is it acts as one unit and it's uniformly distributed. So in other words, sympathetic nerve activity affects the cardiovascular system and it acts like one thing. And so we treat it as one thing. So to treat somebody with overactive sympathetic nervous system, we give drugs that cause global sympathetic blockade, alpha blockers, beta blockers, central sympatholytics. The problem is, if we're talking about hypertension, they may lower blood pressure, but then you knock out all the other things the sympathetic nervous system is important for. So you have the side effects: orthostatic intolerance, sedation, dry mouth, bradycardia, sexual dysfunction. And obviously, especially with somebody with hypertension, which has no symptoms, you take the drugs, you feel worse, you don't want to take the drugs anymore. So the hypothesis that we have been working on for quite a while now is that it's actually a bit more complicated than that. First of all, there's a chronic activation of sympathetic nerve activity. We know that, and we study the idea of elevated salt intake, fat, sugar, chronic stress, genetic causes this elevation of sympathetic activity that can lead to a lot of these problems. But the key difference is that the sympathetic nervous system is differentially controlled in a disease-specific manner, and I'll explain what I mean by that in a minute. And if that's true, then we can target only parts of the nervous system to treat disease and not the whole nervous system. So in other words, organ-specific regulation that's disease-specific. So cardiac sympathetic nerve activity, splanchnic sympathetic nerve activity, renal or lumbar may be elevated or inhibited depending on what the disease state is. Certainly we know in heart failure there's high cardiac sympathetic activity, but probably not much to the kidneys. Maybe there is, maybe there isn't. Now another problem is we have no way in patients to measure this. We can't diagnose whether they have a targeted activation of the sympathetic nervous system. Now, with that in mind, if we think about this feedback loop of the central nervous system and sympathetic activity, and baroreceptors, and I'll get into provide a lot of that afferent feedback, there's two ways we could interrupt with this system. We could either block specific nerves to specific organs to treat disease, Or there's also the idea of doing nerve stimulation to stimulate those afferent pathways back to the brain to reflexly control it. So that's basically what I'm going to be talking about today in terms of using devices. So with that, I'll move into what we've been working on, and this is a story some of you may be familiar with, but in the hypertension world, there's been this story going on for the last 5 or 6 years of going from bench to bedside, and now we're kind of confused where we are in this circle. So I'll give you the background on that. Now, what's important to keep in mind is that what causes hypertension, this developmental phase, and what maintains it are probably very different mechanisms. And clinically, you're looking at people that already have hypertension, and you're trying to reverse that. So I put that out there because that's important in terms of some of the studies I'm going to talk about. Now, when we think about, I'm sure you can't read the slide, but the history of treating hypertension beginning in the 40s was either dietary interventions. A Kempner diet was a diet of rice and fruits and vegetables, which is probably a good idea today. And then here is a surgical intervention, lumbodorsal sympathectomy. So go in, open the patient up, cut the sympathetic roots on each side of the spinal cord and send them home. Very invasive procedure, very effective, lowers blood pressure. But in the 50s, drugs became available. These are ganglionic blockers. This is a sympatholytic drug. Diuretics came on board. Later on in the 60s, we have aldosterone antagonists, beta receptor antagonists. That's a typo there. Alpha blockers come on, the angiotensin converting enzyme inhibitors, and on and on. Probably since endothelin receptor antagonists and ARBs, there's really no new drugs on the horizon to treat hypertension. As far as I know, there aren't new drugs that we are looking forward to coming out. So most of these, or many of them, do target the sympathetic nervous system. So that does lower blood pressure and can be very, very effective in treating hypertension, but they have these side effects. So that led to this idea, well, maybe we can target just part of the nervous system to treat hypertension. And that would rely on this idea that targeted ablation of just a single pathway would mean that hypertension is because of activation of that pathway. And what's the evidence to support that? Well, the world of hypertension, at least in this country, has been very kidney-centric for many, many years, that the kidney is really the primary problem in hypertension. It's impaired regulation of blood volume. And there are many animal models that have been shown where if you denervate the kidneys, you can either prevent or delay the progression of hypertension. So there's a ton of animal models that are shown here. And all of these are developmental phase of hypertension. So this basically led to the idea that maybe in humans, we could target the renal nerves, we could denervate human kidneys to treat hypertension. So in other words, leave all these pathways intact, cut the renal nerves out, and what would that do? Based on the physiology of what renal nerves do, that could lower the renin system, so renin, angiotensin, aldosterone goes down. It would decrease tubular sodium reabsorption, which nerves cause sodium to be hung onto, and it would vasodilate the kidney. All of those potentially could lower blood pressure. And I'm going to throw in another one that I'll get to later, is it also could reverse perhaps renal pathology and renal inflammation, which people with hypertension have hypertension-induced renal disease. So that was the idea. So a few years ago now, there was a startup company out near Google. I visited the company a while back, and they came up with a very simple idea, and that's let's pass a catheter up the femoral, up the aorta, into the renal artery, and let's use radiofrequency ablation, and let's ablate the nerves, because the nerves, I won't touch the screen, the nerves come down, travel along the adventitia of the renal artery, and we can get enough energy there and basically ablate those nerves much like you would do an ablation to treat atrial arrhythmia. So this took off really fast. Medtronic paid $1 billion for this company. 65 or more other companies jumped in on it. Lots of patents were filed and lots of papers were published. And this initial technique was pretty crude. It was just a single monopolar catheter design. You put it in there, you zap, pull it back, rotate, do that 4 or 5 times, go to the other kidney. It'd be about a 1-hour procedure, send the patient home and see what happens. So the clinical trials, which I'll quickly review, the first clinical trial called Symplicity Hypertension 1, it's the Symplicity catheter, was done primarily in Australia and New Zealand. Small number of patients, 45 patients, no control group. And now these are drug-resistant patients. So the idea is that they're on at least 3 or more medications for hypertension. The average is usually 5 or 6. And that was the first clinical trial. The second one was larger, 106 patients, randomized trial. Now they have a control group. One half of the people get the procedure, the other half don't, but the other half know they don't because they don't have a hole in the leg. It's not a blinded control group, and that's going to be an issue that I'll talk about in a second. That went well, and I'll show you some data, but then it came to the U.S., 60 U.S. centers, huge trial, double-blinded, true sham control, and I'll show you that in a second. So this is from the first clinical trial, just to give you an idea of the patient population they're working with. So 57 years old. There's the breakdown on gender. Some of these patients have diabetes, which will become important, coronary artery disease, elevated lipids, baseline pressure 176/98, really hypertensive, average of 5 different antihypertensive drugs. And then this is the breakdown of the drugs that they're on. Most of them are on diuretics, and then the breakdown on the other ones. Now, this was the result of the first clinical trial that set the whole field on fire and got everybody excited about this. And what this is showing you is office measurement of blood pressure, 1 month, so this is systolic drop, 19, diastolic 9. This is then 3 months, 6 months, out to 3 years after a one-time procedure, huge drop in systolic pressure and diastolic pressure. So this was like thought to be, that's why Medtronic paid $1 billion for the company. Now, what people started to report, and they're following these patients out, were other things that were reported in these patients after this procedure, which didn't quite fit with the idea of the nerves to the kidney are being ablated and decreasing all those things I told you about. First of all, in some of these patients, they measured the sympathetic activity to skeletal muscles. So it's a completely different target organ. That was normalized by denervating the kidney. Some patients that had elevated glucose, that was normalized by denervating the kidney. Some patients have arrhythmias. Those went away by denervating the kidney. Some of them had sleep apnea. That went away. So this got a lot of attention on why that would even be happening. And the idea is, in that story I'm going to build here, is that there are sensory nerves in the kidney that project and send signals to the brain that can then influence the entire sympathetic nervous system. And maybe the diseased kidney is driving the nervous system and causing all these other problems. And I'm going to focus on the glucose because we're looking at this in some of our preclinical models as well. So the idea is you have the renal nerves and they control these things, the renin, sodium retention, renal blood flow, but then you also have these afferent nerves that communicate with the brain and can then result in all these other effects in terms of arrhythmias, cardiac hypertrophy, insulin resistance. And so we don't know if denervating these nerves are what's beneficial, okay? So it was kind of, we're not really sure what's happening, which is the basis of the grant I have right now, is to try to figure that out. But then we get to the US trial. And this was highly anticipated, especially those 65 other companies that were working on this technology. So multi-center trial, a true sham group, so they put the catheter in, half the people don't get the ablation, half the people do. They did both in-office blood pressure measurement as well as ambulatory monitoring, which is important in terms of more accurate measurement of blood pressure. Patients were blinded to the procedure, and it failed. It didn't work. They had to stop it at 6 months based on failing to reach their efficacy endpoint. Now, what does that mean? That just stopped the whole field in terms of what was being done. So in terms of clinical questions, this is where the field is now. So a lot of companies dropped out. Everybody's on pause. So first of all, how do we know who to treat? There's no way to diagnose somebody and say, you have too much renal nerve activity, so therefore you should get this procedure. They're basically just denervating people that have hypertension. How do you know if you did the procedure properly? That's the other problem with this procedure. There's no way to know you did it right, other than if the blood pressure fell. So with that with the US trial, so back up, in Australia and New Zealand, everybody that did the procedure was trained by people that knew how to do the procedure, and they had to do many, many of them before they actually did it in people. In the US, some of the people did the procedure 1 time. Some of them maybe did it twice. So they were not trained properly, They didn't know if they did it properly because there's no way to know because of the technique. So I'm skipping over a bunch of the literature now, but it's pretty much been confirmed that the trial failed because it wasn't executed properly in terms of doing the procedure, which is unfortunate. So the big thing now is, can we make better catheters and do better ablations? In the hands of the very best person with that first catheter I showed you, you can get about a 50% ablation, and that's it. It's about as good as it gets. Now, in terms of what we do in basic research, we came in and to say, well, let's look at how this might work and how we can improve it. So does renal ablation reverse the established phase of experimental hypertension? It was something we wanted to look at. Then this idea, are the sensory nerves important or are the nerves to the kidney important? And the reason we want to know that is if somebody may want the innervation of their kidney intact to control their renal blood flow and their renin release and their sodium reabsorption. And if the afferents are doing the whole deal, let's just target the afferents. So we wanted to look at that. And then I got just intrigued by the idea of effects on glucose metabolism. So it could really be denervating the kidneys to help both hypertension and diabetes. I mean, if it does, that would be great. So I'm going to introduce one last piece of evidence that came out recently to just set the stage. This is a paper in Circ Research by David Harrison's group. He was here last year as Jay Cohen's invited speaker. David's at Vanderbilt, and I said my PhD student there is doing a postdoc right now. This just came out a few months ago, and this is a model of hypertension in the mouse where they give angiotensin. And here's the increase in blood pressure by giving angiotensin to these mice. These are mice where they denervated their kidneys first, and this has been shown in other models. They attenuate the hypertension quite a bit. That's not necessarily news. What is news is they also looked at the kidneys of these mice, and they looked for markers of T cells, macrophages, and basically fibrosis. So in the top panel here is a marker for T cells, and in this bar graph, this would be a normal mouse. A hypertensive mouse has more T cells in the kidney, which is going to release inflammatory cytokines. If the kidneys were denervated, they don't get the trafficking of T cells into the kidney. So this is the new part, which is kind of the big buzz in hypertension now. Are nerves important in terms of trafficking T cells into the kidney? This is the marker for macrophages where there was no effect of the denervation. And then here we're just looking basically at fibrosis, so you can see that's increase in hypertension. And the denervation prevented that. So this brought up another possible mechanism where renal nerves may be affecting the kidney and causing hypertension. So we come back to this idea of the autonomic nervous system and the sympathetic nervous system, and that it may be inflammatory and maybe elevated sympathetic activity causes hypertension because of inflammation. And then the idea would be if we can cut out just that nerve right there and leave everything else intact, maybe that would be a good treatment. So that's how we entered this whole idea. So here's the basic overarching hypothesis. The efferent nerves in red to the kidney cause inflammation of the kidney directly. That's the initiating event. The inflammation in the kidney then is going to cause this afferent activation. And increased afferent activity goes to the brain, as I showed you, and causes hypertension, insulin resistance, sleep apnea, and those kinds of things. And if that's true, then we could target only these sensory nerves to treat these disorders. That would be the idea. So we had to come up with a way to do that. That wasn't possible at the time. And this is Jason, who did his thesis work in my lab and really developed this method, which launched everything that we're doing at this point. And what I'm trying to show here, so these are the nerves to the kidney. The red would be the nerves, the efferent nerves to the kidney, which would be over here. The blue would be the sensory nerves. And the key is, so the efferent nerves release norepinephrine that act on their target. The afferent nerves are sensory, and they have a channel in their axon, the TRPV1 channel in the axon, that responds to the application of capsaicin, the red hot chili pepper ingredient. And so it's a very simple technique once we got it worked out. You just expose the vessels to the kidney. You take some gauze that's soaked in capsaicin, put it on your tongue, it really burns. You leave it there for 15 minutes, you take it off, and you put the animal away, and that capsaicin acts on these receptors. There's a huge influx of calcium that causes death of the cells. So basically it kills all the sensory nerves. So Jason quantified that or showed that work. So this is a cross-section of the kidney. Red is an antibody for tyrosine hydroxylase, which is the marker of the efferent nerves of the kidney. Brown is CGRP, that's inside of the sensory nerves. So this would be a normal animal. This is an animal that's been treated with this capsaicin. You can see they still have the red efferent nerves there, but there's no sensory nerves at all. Now the quantification is shown here. So this is tyrosine hydroxylase, the efferent marker. 10 days after treatment, the black would be the normal animal. This is the treated animal. Nothing happens to the efferent nerves, 4 weeks or 7 weeks. But over here, this is the marker for the sensory nerves. And you can see it's well, not completely, but pretty much gone after 10 days after treatment, 1 month after treatment, and by 7 weeks or so, it's about halfway back to normal. And this is identical to what you see if you cut nerves, completely cut them, you'll start to see the neurotransmitter come back at about the same rate. And this is showing the same thing, but with just different markers. This is immunohistochemistry. This is doing assays for the neurotransmitters. Same result. So that's fine. Anatomically, we see the neurotransmitters go away. But what about functionally? So the way to show that these nerves don't work anymore in an animal, a conscious animal, is a catheter is fed up into the renal artery. And then in an awake animal, we inject bradykinin into the renal circulation, and that's going to activate those sensory nerves. And when you do that, it activates these nerves and causes a sympatho-excitatory response, or an increase in blood pressure. So that's shown here. So this is the increase in blood pressure in a normal animal when you inject bradykinin into the kidney. This is an animal that's been treated with the capsaicin, and you see you've completely lost the cardiovascular response. Same thing, heart rate goes up with the bradykinin, and you block that with the capsaicin. So that tells us that we've functionally gotten rid of those afferents in an unanesthetized conscious animal. This is just intravenous infusion to show that that injection is acting, doesn't do anything systemically. It's all based in the kidney. So at that point, we got a technique. We can take out just the afferent nerves, and we've been systematically going and look at many models of hypertension to see if these play a role in hypertension and in metabolic syndrome or metabolic conditions. We've done a bunch of models. We've actually got one more to add to this. I didn't put it on the slide, but I'm only going to talk about a couple of them. And I want to make the point that all of these models have the two things that we need for our hypothesis. They have elevated sympathetic activity, and they have bad kidneys, renal pathology. So I'm going to talk about two of these models today in terms of what we've been doing in our lab with this approach. So the idea here then is very simple. So if we have a stimulus that increases blood pressure, and we have animals where we denervate these kidneys completely, which takes out all of these nerves, and we say we attenuate the high blood pressure, then we come back and we take out only these sensory nerves, not a complete ablation, but just a sensory nerve ablation. If we get the same effect as a total ablation, then we're going to say, well, when we did this denervation, the reason it worked is because these afferent nerves are the ones that are doing all the business. So on the other hand, if we do the same thing, if we do a denervation, total denervation, then it works, but we take out then just the sensory nerves and they don't do anything, well, we'd conclude renal denervation lowers pressure because it's all the efferent nerves. So that was the kind of simplistic idea of the approach that we were using. So I'm going to talk first about a mouse model of spontaneous hypertension. And I put why I studied the mouse, because we've always used rats because we can do physiology in rats. We do a lot of stuff where we measure blood pressure, heart rate, blood flow, nerve activity. In a mouse, it's really hard to do. But we had some reasons to start studying the mouse. You can use genetic approaches, and we thought if this pans out, there's some nice mouse models where you can knock out certain inflammatory mediators that might be useful. I used to be in Jackson Hall. Now I'm over on the other side of the football stadium. We have all these facilities for doing work on inflammation and metabolism, and so they're kind of designed mostly for mice. We do rat work too, and I also feel like you need to study many species to look at the question, not just one. And then this brings in the collaborators too that I've been working with that all pretty much study mouse models. So Alessandro in our department works on the interaction of stress and high-fat diet and its effects on the sympathetic nervous system and metabolism. Yogi, in addition to being an amazing MSTP administrator and all the other things he does, is also an expert T-cell biologist, and he was helpful to get us going with this. And then Angll as well in terms of looking at cytokines and inflammation has been really helpful to get us going. So this is the work of Nanitha, who's sitting in the back. When she came to my lab to do her postdoc, she wanted to work on metabolism and she wanted to work on mice. So that was the other reason to do mouse studies. And so the basic hypothesis is shown here that in this genetic, so this is a genetic form that's basically been inbred to have hypertension. So I don't know what the stimulus is, but they have high blood pressure that activates the nervous system. So the idea is that increases renal nerve activity, causes infiltration of T cells, which release cytokines, and we get renal inflammation and hypertension. And then the idea, again, as I said, you either do a total denervation to look at this process or a selective sensory denervation. So the mouse is called the Schlager mouse model, or the BPH for blood pressure high. And we also have a control, BPN, blood pressure normal. And the hypertension has been shown to be due to increased sympathetic activity. They also have a high metabolic rate, and I may get to that or maybe not. So they're color-coded. The BPH are white, the BPN are black. And so what Nanitha did in this study, at 8 weeks of age, they're entered into a study and put on a specific diet. And I'm not going to show that data today. We have them on either a high-fat diet or low-fat diet. And that's not going to be part of the story I'm talking about today, but they're on this diet for a certain period of time. And then we do a cardiovascular study where we implant them with a telemetry transmitter to measure blood pressure 24/7 while they're in their cage. Let them recover, we get controlled blood pressure, then we do a renal denervation procedure, and then we wait for a number of weeks and we collect tissues, and I'll show you what we got from that. Now these animals have this transmitter in them, which means we can't put them in an echo MRI machine to measure body composition. So another group is run where we do a metabolic protocol without blood pressure, and we look at their glucose metabolism, and I'll show you that data in a minute. So in terms of measuring blood pressure in these guys, so there's a transmitter. It's a wireless transmission, telemetry transmitter that's implanted in the animal. And these guys also have an ECG electrode, which wasn't necessary for this particular study. They're put back in their cage. This goes through a computer, and this is a typical trace, arterial pressure and ECG that we collect pretty much around the clock. So this is a study in progress, but it shows you the main result on blood pressure in this particular strain. And what you see up here, so this is the hypertensive strain here. You see they have mean pressures of about 135, so they definitely have high pressure. Renal denervation drops blood pressure about 10 millimeters of mercury in the hypertensive animals. If we do a sham procedure, nothing happens to blood pressure. Now, in contrast, these are the normotensive animals. Renal denervation does nothing to their blood pressure, neither does sham. So this drop in blood pressure in this strain is specific to the fact that they have hypertension. So that'd be similar to what's been reported in human studies. Now, glucose metabolism, it's interesting. Now, these are very lean mice. The percent body fat is less than 5. They have almost no body fat. So they don't have, it's not like glucose is impaired. Glucose metabolism is impaired because of obesity. They're actually lean. But they do have impaired glucose metabolism. This is the glucose tolerance test. So we inject glucose in the lean animals. It goes up and comes down. Hypertensive strain, a huge increase in glucose in response to that intraperitoneal injection, meaning they have impaired uptake of glucose. This is just the area under the curve that shows that. So similar to some hypertensive patients, also impaired glucose metabolism. Now, renal denervation in these animals tends to improve glucose metabolism. So these are the hypertensive animals, sham, or if we do the renal denervation, it's not big, but there seems to be something there. So this is N of 4 to 6 in each group, and you can see the area under the curve. There's a tendency for it to improve, so we'll see if this pans out. But this would be consistent with some of the studies that have been done in humans. In contrast, in normotensive animals, there is no effect of renal denervation on their glucose metabolism. So this is consistent with the idea there's some signal from the kidney that is important in terms of that impaired glucose metabolism. Now, Nanitha's also been looking at some markers of inflammation, and this is based on doing RT-PCR. So this is for TNF-alpha, so this is in the kidney itself, which is definitely elevated in these hypertensive animals. Renal denervation for this particular marker did not have any effect on this inflammatory marker. But if we look at IL-1 beta, that's also increased, but that is normalized by renal denervation. And again, this is at the established phase of hypertension. So we're also now in the process of looking at the actual cytokines themselves and some other markers. So this suggests there may be a reversal of some renal inflammation with renal denervation. So what Nanith is doing is going to be looking at just taking out the sensory nerves to see, does that lower blood pressure? We have preliminary data to say if you do only the sensory denervation, you also lower blood pressure. And she'll be looking at glucose metabolism too. So early results suggest this model may be entirely due to this afferent signaling from the kidney. Similar figure, another postdoc, Chris, who's sitting here, came in and he's been working on the DOCA-Salt model of hypertension with pretty much the same hypothesis in terms of the role of the renal nerves driving inflammation and hypertension. So what is the DOCA-Salt model? What is that? So DOCA is a precursor to aldosterone, so it's like aldosterone-induced hypertension. You know that aldosterone blockers are used for treating hypertension. So you give animals basically this mineralocorticoid and you give them a high salt diet and they develop high blood pressure. So, and to make sure they get high blood pressure, we take a kidney out first and then we put in a transmitter and we either denervate a kidney or we take out just the sensory nerves of the kidney or do a sham, and then we make them get hypertensive and we see what happens to the development of the blood pressure. So this model shows this is the increase in blood pressure caused by the mineralocorticoid and salt, and this is over 3 weeks of time. So animals that have not been, had no intervention, their pressure goes up about 30 millimeters of mercury. This is a control group that didn't get the mineralocorticoid or the salt, so that's our control. Now, you can see here these two lines. So the yellow line is total renal denervation, afferent and efferent, and we attenuate the hypertension by 50%. That's a huge effect on the development of hypertension. Now, the key is the green line is if we took out only the sensory nerves, and it's the exact same effect. So if we can take out just the sensory fibers from the kidney that go up to the brain, we prevent half of the hypertension, suggesting that this is the important pathway. Now, Chris has been looking at different markers of inflammation as well, and I'm showing two of them here, so let's focus on this one. This one is basically a marker for macrophages. This is a control animal, so this is in the kidney tissue again. Hypertensive animal after 3 weeks. If animals were denervated first, not only does it normalize that marker, it actually goes below normal. They do not get that infiltration or that increase in GRO-KC. Afferent denervation also lowered it from these guys, but not quite as much. So MCP1, the same pattern here. And Chris has looked at a bunch of them. So it's basically all of these sides. So IL-1 beta, IL-2, IL-6. Pick the one you want to look at. It's pretty much the same pattern. So increase with hypertension. Renal denervation not only prevents it, but actually puts it down below normal. And afferent denervation tends to normalize it. Now I'm going to point out, I'll go back. The afferent denervation lowers blood pressure. The total denervation lowers blood pressure the same, but also you lose the innervation of the kidney. So some of that effect of the afferent denervation may be because pressure is not as high. So we think there's a pressure-driven inflammation, but also a neurogenic-driven inflammation. So to look at this more directly, what Chris has been doing is going into a record from these nerves electrophysiologically. So the animal's anesthetized at the end of the protocol. Electrodes put around the renal nerves, and then you make a cut right here. So the only signal coming across that electrode is what's leaving the kidney and headed in this direction. So this is a sample. So this would be an experiment with an animal anesthetized. The top trace is arterial pressure. He puts a catheter up through the ureter into the pelvis of the kidney. You can measure bladder pressure. This is the raw nerve activity. And basically, if you want to just get the bottom line, this is the integrated signal. This is showing with an increase in pressure in the renal pelvis, you activate these afferent nerves. So we know they're mechanoreceptors. There's a bunch of things that activate them. Now, what Chris did, I'll go back, it's not on this slide, but basically what he does when the animal's there is he injects into the kidney a maximal dose of capsaicin, which causes that activity to go to the ceiling, maximal activation. So we call that 100, and then we have the 0, and then we normalize to that maximal level of activity. And when he does that, what he shows, so this is blood pressure in these animals under anesthesia. It's elevated. This is the baseline afferent nerve activity, meaning the tonic firing of those nerves coming from the kidney going to the brain, and it's basically doubled. So this shows that these nerves are in fact firing at a higher frequency in the animal with hypertension. So far in this model, it's consistent with the idea the efferents we think are important in driving the inflammation. There's definitely increased afferent nerve activity, and if we take out those afferent nerves, we attenuate the hypertension. So far that is fairly consistent. So I'm going to move on, and the last couple things are shorter in terms of these other approaches that we're using now to talk about vagal nerve stimulation, which is basically a way to modify the afferent inputs. So we know we have carotid baroreceptors and aortic baroreceptors, and we have chemoreceptors, we have cardiopulmonary receptors. All of those go up the vagus nerve, up to the brain, and carry that information. So we've talked about doing nerve ablation. Now we're talking about neural stimulation. Some of you may know that you can do carotid sinus nerve stimulation for treating heart failure and hypertension, but this is basically the vagus nerve. I got this out of the New York Times almost 2 years ago now. Vagal nerve stimulators are in lots of people and in clinical trials for lots of things. And so the graphic, which I like to point out, looks like a nosebleed, is actually pointing to the vagus nerve coming out of the brainstem. And you can implant the stimulator around there, and is being used in clinical trials for all of these things, which is crazy. So when engineers first told me about this, I thought, you don't have any idea what the vagus nerve has lots of things in it. In fact, the vagus nerve, here it is, 10th cranial nerve, has about 100,000 neurons in it. 80% of those are actually going to the brain, and 20% are leaving the brain. And they're stimulating it and hoping it does something to the thing they want to study. Well, we decided we'd look at that too. So in collaborating with Elena's lab, we chronically implant right now a vagal nerve stimulator in the right cervical vagus nerve in a genetic model of hypertension. It's a salt-sensitive model of hypertension. And we look at hypertension as well as arrhythmias. Her lab specializes in looking at arrhythmogenesis. And so the idea is to look at arrhythmias, look at the peripheral pathways, and basically figure out how it works. So it's kind of hard to see, but the vagus nerve is isolated. The electrode's implanted chronically, and we do the stimulation for over a month in these animals. So here's the blood pressure measurement in a chronically instrumented animal, and here's the ECG. We know that the stimulator's on because we get a little bit of noise in the electrocardiogram for the ECG. Now, we published this paper just recently. Beth was sitting here too as the first author on this paper, is working hard on this to this day. This is the increase in blood pressure in this strain. So this is over 30 days here. This is a Dahl salt-sensitive rat. With vagal nerve stimulation, we attenuate that by about 20 millimeters of mercury with chronic vagal stimulation. I'm going to point out, I haven't presented this study. This is the same strain of animals that get high blood pressure. And if you just look at right here, these are animals that develop hypertension. One of these groups is a renal nerve ablation, which drops pressure by 10. The other one is a splanchnic denervation, which drops by 10. And if we add them together, we drop by 20. So the idea is the vagal nerve stimulation may be shutting down the sympathetic activity to both the kidney and the splanchnic circulation. That's the hypothesis. This also reverses some of the arrhythmias. So this is showing rhythmogenic events. These are spontaneous arrhythmias in these animals. This is showing PVCs before and then after 4 weeks of high salt, either no treatment or the treatment. So in fact, you do reverse some of these spontaneous arrhythmias. So the basic idea, this grant was just reviewed. We need to go back in, I'll just say that. We'll wait and see what they had to say about it, but it's to really look at right versus left and then try to figure out, is it working the same thing because of afferent stimulation to the brain of the vagus nerve, or are we stimulating things distal to the vagus nerve? in terms of both cardiac and blood pressure effects. And then we're also looking, I want to point out, this is a recent review by Kevin Tracy, who's pioneered this idea that vagus is actually really important as an anti-inflammatory system. He started with this to treat people with arthritis, and has had great success. So that New York Times article I showed you is a bunch of his patients that have basically couldn't even walk because of arthritis. Now they're up walking around after vagal nerve stimulation. So we're looking at that aspect of it as well. Okay, I'll finish up with a couple slides with this most current collaboration with Manda. So Manda came here within the last year. She did her postdoc at the Mayo Clinic with Michael Joyner and Bruce Johnson. And her postdoc work was looking at heart failure patients and the response to exercise. So you probably all know that when you exercise, your blood pressure goes up, and so does your sympathetic activity. People with heart failure have exercise intolerance. Sympathetic activity goes up too high, and it's a problem. So the idea is, can we do something about that? So here's Manda working on a subject there at the Mayo Clinic, where basically they have them exercise, they measure cardiovascular variables during the exercise pressor reflex, and try to treat that in a way that would be beneficial. The first approach they've used is by actually blocking the input to the spinal cord from the muscle. So these muscle afferents come in and drive the sympathetic nervous system. So if you look at injecting the patients this receptor agonist, fentanyl, to block the afferent input, it's a pain medication, is that useful in treating exercise-induced increases in blood pressure and heart failure? So this is from one of Manda's studies. So this shows the blood pressure response during exercise. So this would be in a control situation. If you give fentanyl into the spinal cord, you can see you attenuate the hypertension and the sympathetic response. These are heart failure patients, and you get the same effect. So this could be beneficial in terms of somebody with heart failure during exercise. The idea is now to use it in hypertension as well, which Amanda's trying to set up here. So, but you can't put the catheter in and have people walk around with that all day. So the idea is to do neuromodulation by using spinal stimulation to block those impulses into the spinal cord. So the concept would be to do that. And also people with hypertension have the same problem. We say you should exercise. Some people, their blood pressure goes too high during exercise and it stays up for too long. So this would basically prevent that exercise-induced hypertensive effect. So Amanda's getting preliminary data. This is men, this is women. This is 100 hertz stimulation, 1,000 hertz. So basically looking at how this can, and these are normal patients, the blood pressure response. And it looks like maybe in women there might be an effect with spinal stimulation to inhibit that, but we need to increase the numbers to show that. So Amanda's getting that set up here. So we're looking forward to basically collaborating, Amanda's lab, my lab. So we have a treadmill for our rats right now. We have hypertensive rats. We have a way to put electrodes in, and we're going to see if we can treat exercising hypertensive rats, and then work out how to translate that to help Amanda with her studies in humans. So I'm about done. I'm going to finish with this. So this comes together. So NIH has a brand new initiative to develop autonomic neuromodulation. It's called SPARK, for those words right there. Basically, it's $250 million over the next 7 years from across all institutes. And their idea is basically what I've been talking about, to promote studies to develop new or enhance existing tools and technologies to elucidate the neurobiology, neurophysiology, and underlying autonomic control of internal organs and health of disease to develop these neuromodulation therapies. This isn't just for hypertension or heart failure, diabetes, obesity, anything, where you can find the peripheral nerve, you know what it does, now you go in and you can target it to either stimulate it or inhibit it. And so that's where this is going in terms of device-based treatments and what we're trying to put together. So we're right now at the beginning stages of putting together this partnership. We have all the lawyers that agree that we can work together. So preclinical studies and clinical studies with Amanda would be done here at the University of Minnesota. We'll continue to work with the Mayo Clinic doing human studies down there. And we have partners at Boston Scientific to develop the devices, the leads, and work together on that. So we're trying to get all this off the ground basically right now. That's what I've got. So Nanitha, Dusty, Chris. This was at the hypertension meeting of the American Heart Association. There's one other person that wasn't there, Madeline, who's the undergrad in the lab, who's given her first talk at a meeting in April. And as I said, applying for MSTP programs, so watch out for her. That's what I've got. Happy to answer any questions you might have.
Questions for John?
Yeah.
Do you foresee a second coming of renal nerve denervation with improved device technique, et cetera? Because it almost seemed that the time kind of rushed it.
They did, yeah, yeah. I like the way you said second coming, which means you're a believer. I get that. That's the tone I'm getting from that question. Yeah, there is. So they're still in the game. Other companies are. Now, they've now come out with catheter designs where they basically blow it up and there'll be like 6 electrodes all placed in 30 seconds. You do the procedure. But they are working on those things that I told you. You need to know if you did it properly, and you need to know who to treat. So they're not going to come out with the next clinical trial until they know it's going to work, because if it fails again, it's out. But that did open up this whole world of using devices for treating hypertension. So there's the idea of targeting other nerves, using cryoablation, all kinds of technology has been started by that. So I definitely see it coming back. Yeah. Yeah.
How do you know which file is the best and what's better down the road?
Yeah, I'm glad you asked that question. So we've done about 7 different animal models, mouse and rat, and I can tell you, in some models, renal denervation does nothing to blood pressure or anything. In some models where it works, it's all efferent. In other models, it's all afferent. And so getting to humans, what we want to figure out is, how do you know what's what? How do you know what's driving inflammation? So if we get those details, then we can say, well, in this person, in this patient, we would know if this is going to work or not. So some people say stick with the model that works and do your research, but it is model dependent. And in humans, of course, there's all different causes of hypertension. So we're looking at many models, and it works in some and not in others. So I don't know how. We've done obesity-induced hypertension. You can completely normalize blood pressure by renal denervation in that model, and that's all because of the efferents. So there's, and in lots of patients, you know, there's definitely obesity to drive it. So we've done that one, the genetic model. Those are the 2 main mouse models. We put that in several different rat models.
Any correlation to
Yeah. That's been the big discussion. So in humans, you can put an electrode in this nerve right here in the knee, and you can measure that directly. So the question comes up, well, does that even cause hypertension? Nerve activity of the muscle. If not, is this a surrogate for the renal nerve activity? And there's been debate back and forth on whether that's true. So the answer is we don't know. One idea to test if somebody should get the renal nerve ablation procedure, put them on a maximal dose of clonidine, which knocks out the sympathetic nervous system. See if it drops their blood pressure a lot. If it does, it means they have high sympathetic drive. So treat that person. If you don't get a response to clonidine, don't treat that person. So that would be a way to kind of assess global sympathetic drive as a treatment. So we've had, I consulted for Medtronic for 3 years. We met every year. We got everybody in the room to decide how to tackle this in terms of who to treat. That's the best idea we've come up with so far.
I'm particularly interested about the first study from Australia, which was
Yeah.
it was persistent for 3 years.
Yeah.
Anticipate that
So we know from animal studies that if you measure the neurotransmitter, that will come back, but that doesn't mean they work. That doesn't mean the nerves are functional. So you would expect in these patients that eventually they might get renervation. It's the same thing with heart transplant or whatever. It may take a long time to come back, but they eventually may come back. So the issue has been discussed on whether you go back in and denervate again. Now, the fact that the pressure went down and stayed down that long kind of surprised everybody. Nobody really can figure out why that would have happened. Reverse remodeling of the vasculature in the heart, stuff like that. But the renervation thing is definitely a concern.
can't remember any other study like the renal denervation study.
Right.
Where there was so much positive preliminary data, and then the thing just falls flat. How did that happen? I mean,
I think it happened because people got greedy, and they tried, if that clinical trial succeeded, it would have been great, and so they pushed it. It was done in 60 different centers with people that weren't properly trained. And I think some people thought it's an ablation catheter, how hard can it be? But the fact that there was no way to know that it works, I mean, they just rushed it, and it's pretty clear that they just didn't execute it properly. Yeah, yeah.
that last one thing, circulation. Anyway, something about comfort. Some people looked at the trial design, and they looked at the amount of blood pressure lower relative to the number of biopsies that were in the trial. And as you decrease the number of biopsies, the amount of blood pressure goes down as well. So is that an explanation? It's compatible.
Right.
And there may be multiple reasons why you get these. It's probably, if there is a history of better quality studies, fewer bias showing less than early studies.
There's one that came out of France where they basically took the patients and they said, let's maximize your medication first and make sure you take it, track it, looked at the blood pressure response to that, and then they added on denervation after that. And got a small effect, but it was significant. And then there was another trial that did not see that. So it certainly gets to the patient population. One thing in the Symplicity 3 is the placebo group, the sham group dropped. But, and then the treatment group did. In the sham group, the black population, sham controls dropped by 15 or 20 millimeters of mercury. And the issue is, did people change anything about their medications, about their lifestyle? So all of that made it very difficult to figure out what went wrong. I mean, this has been analyzed a lot. So, yeah. So what I always said to Medtronic is that, so in our studies, we know we denervate the kidney. We measure the catecholamines, 100% denervation. In humans at best, it's 50. If you can come up with a way to get an effective, complete denervation, it will lower blood pressure. So I think there's a definite technology aspect.
All right, well, thank you, John, very much.
Sure. And so even the trainers were not qualified. You know, the money that they put into it, I know, it fell so flat.
Well, it hasn't gone away.
Oh, we're working on it. Gary, you met him? I know, right. Yeah. So, Mandy, I mean, we're trying to get her time going to film movies. Yeah, I said, it's great to go to the mail. Yeah, right. So, we're going to struggle in terms of not having
Years ago, we did a lot of things.
Yeah, right.
Now, the heart failure, they're so different. Peter was also